Are pharmaceutical companies or doctors reimbursed, rewarded financially for prescribing pain meds? Not directly by the pharmaceutical companies, but they are by the insurance that the patient has or the patient pays them out of pocket. It sounds like this is starting to be addressed. Yes, it is starting to be addressed. The DEA is actively looking at pain clinics all over the state. And, you know, I can tell you that I've had the DEA come to my office. What do they come to my office for? Because I prescribe buprenorphine. You know, it's ridiculous. I mean, you don't want to tell them that, but as the pendulum swings back, how can we ensure people who really need pain meds can still get them? That is a very, very important point. You know, we live in a society of fads and trends, and the pendulum swings from one extreme to the other, and balance is that brief point in the middle where the pendulum is accelerating by as it goes to the other extreme. There are now elderly, frail patients in the nursing home or living independently, etc., who really genuinely need these medications, and physicians are beginning to be afraid to prescribe them because of monitoring. Don't worry about that. As long as you document, you know, what the condition is that you are treating, you're not going to get into trouble. Does evidence really show that alcohol, tobacco, marijuana are usually gateway drugs for addicts? Well, I think that's a really important question. Are there any gateway drugs? I would say that life is a gateway drug. You know, what you need to understand is that people who do drugs or alcohol, they are looking to fix an uncomfortable emotional state. They want something that's going to numb this out, that's going to shut off that shame dynamic, that's going to shut off that uncomfortable internal dialogue for just a little while and give them a break, you know? And so what they're going to do is they're going to try stuff until they find the one that does it for them. Now, I can tell you from having worked with opiate addicts for a long time that most heroin addicts are very monogamous. Once they discover heroin, the only thing they do is coffee, cigarettes, and heroin. You know, is marijuana a gateway drug? I would tell you that marijuana is a gateway to criminality, all right, in the current system. I'm not sure about, you know, whether things should be legalized or not. I don't want to get into that debate. But I think as psychoactive drugs go, marijuana is among the least harmful. However, because it's illegal, that creates a black market. And most people who deal pot, not most, but some people who deal pot also deal other drugs. Now, if that person, you know, is out there looking for the thing that, you know, is going to fix them, they're going to try it until they find it. But a lot of times, once they find it, they'll stick with it. And they'll stick with it, they'll run with it until it starts causing problems. If you really want to know the phases of drug addiction or alcoholism, it's right here. The phase 1, fun. Phase 2, fun with problems. Phase 3, just problems. Anybody else? Yes, sir.
What's the average length of time for treatment of methadone or buprenorphine?
Excellent question. For methadone, 36 months. Look, when I make the diagnosis of addiction or alcoholism, that's the, when you're drinking or drugging causes trouble. And trouble comes in one of 6 varieties: romance, finance, health, family, work, or the legal system. If you got trouble in any of those areas related to your drinking or drugging, you're either alcoholic or drug addicted. Most of the people that come to methadone clinic have trouble in all those areas. And I mean, they have real trouble. Some of them have done time, et cetera, et cetera. So they need a long time, 36 months for methadone, minimum 18 months for buprenorphine. The biggest problem that I have in treating patients is they get in a big hurry. They come into methadone and their attitude is, I want you to give me the minimum amount of methadone for the minimum amount of time. I'm going to wean myself off of it and my life's going to be great. And you know what? That never happens. Double underline never. Relapse rates like 95%, most of them within 2 weeks. So this idea of rapid wean, big mistake. Thank you. Yes, sir.
Going back to trauma patients that come in on methadone or morphine, do you have any preferred short-acting opiate agents that you recommend to use on top of those?
Well, I think if someone's on really high dose buprenorphine, like 24 milligrams, and that's going to occupy somewhere between 95 and 97% of their opiate receptors, you know, you need something that's potent and short acting. So I would go with fentanyl in that situation. In terms of methadone, I would. And then once you get them through the phase where, you know, the buprenorphine has gotten out of the system, you can wean them off the drip and put them on, you know, the standard stuff, whatever that would be. But in methadone, use short-acting opioids, you know, morphine with a half-life of about 4 hours or so. I think IV morphine would be fine. You don't want to get into really long-acting drugs like OxyContin or MS-Contin or anything like that, because, you know, that's putting another long-acting half-life on top of a long-acting half-life drug. It makes the eventuality and predictability of respiratory arrest very difficult. Okay, I think we're done. Thank you very much. I appreciate your attention.